Hey, what's up, everyone? We're live, and I got a special guest today. I have Dr. Jeff Lee, all the way from Toronto, Ontario. My man, Jeff, welcome to the show, my friend.
Hey, what's up? So thanks so much for having me.
No, man, it's honestly it's my pleasure. Dude, I know like you went to school at University of Pennsylvania, an Ivy League school. You then went to school at Michigan for your Perio residency, and now you're working in Toronto. You're a huge Toronto Raptors fan, man. I think it's amazing, like your journey on how you got here, and I want everyone to know, like, who is Jeff Lee, man? Tell us about you, buddy.
Yeah, so I mean, where do I start? I was born in China, but spent a
What?
lot of
You're born
time.
in China? I didn't know that.
Yeah, a
Man,
lot of
that's
people actually
wicked.
don't know that, but the next big thing is I lived in Sweden for 3 years before I moved to Canada.
That's where you get your blonde hair from. Okay, okay.
Yeah,
Sweden. All
pretty
right.
much. Yeah, all my friends were blonde. I was like the only non-blonde in the whole class. So yeah, my family spent a little time there on kind of a stopover, I guess, before we came to Canada, and then we settled in Toronto. So I kind of grew up here.
Yeah.
Have been a Raptors fan since high school, middle school. I probably, Vince Carter days.
Oh
So
yeah,
I,
yeah,
I've
yeah.
been through the lows. So that's why 2019 was really really special for me.
Yeah. Man, did you
Um,
ever go see a game in Skydome? Like back in the day, back in the day?
no, no,
No?
I definitely. I don't think that was a long time ago. I don't think I
Yeah, that
was.
was like as soon as they came, like that was like Damon Stoudemire days, right?
Yeah, exactly. That
Yeah.
was like inaugural year, pretty
The
much.
inaugural year. Yeah, yeah, yeah.
Yeah.
Man, I know you're a huge Raptors fan. Before we get into dentistry, you gotta tell me, man, who's your favorite Raptor of
Right
all time?
now,
All time. No, all time.
of all time, it's probably Vince Carter.
Really, hey? Man, I felt like
But
he
he's
stabbed me
very,
pretty
very
good
close
during
with
that time.
Kyle. I'm a huge
Yeah.
Kyle Lowry fan.
Yeah.
I know the way Carter left a little bit of a sour taste in
It
our mouth.
did, man.
But I remember just watching him. He excited the whole country. I
He
think,
did.
yeah, and I think that made a huge kind of movement of basketball in Canada. So
Yeah, it totally changed
yeah,
basketball again. Man, I'm sorry to derail you. I could talk to
I
you
don't
about
know.
basketball all day, man.
Yeah, we could talk that for next whole
Okay,
day.
so Sweden back to Canada, and then what?
Yeah. Yeah, so I grew up here, went to high school. I went and did college or university at London, so Western Ontario,
Oh, okay.
and then I went to UPenn for dental school. So
Yeah.
after graduating from university, so I went straight. I never got to kind of practice as a general dentist, and I went straight into Perio after that
Okay,
in
okay.
Michigan,
Yeah.
and that was 3 years. And then I actually worked in Boston for a couple of years before I came back to Toronto. So an associateship there with a pretty large Perio group, and that
Okay.
was a really good learning experience. I kind of looked at it like almost like a fourth and fifth year residency,
Okay,
um,
okay.
with a little bit of pay, which is always nice.
Yeah, no kidding, man. I
Yeah,
think that's pretty cool. I want to ask you more about your like UPenn journey, but we'll get into that in a couple seconds. I guess I first met you when you started teaching for the Bites Institute, and you were teaching out in Toronto. And
yeah,
I got into your soft tissue course, and that was the very first soft tissue course I've ever taken. And you actually taught me how to do a free gingival graft,
yeah,
and I thought that was wicked because you made it so easy and almost accessible for an everyday GP just like me.
yeah,
But like more on that, like you don't really, you're a pretty stoic dude. Like you're level. I've known you for quite a while now. Nothing irritates you. Nothing excites you too much. Nothing brings you down too far. Like you're just even plain, like how a periodontist should be, man. But like, do you love teaching? Like what do you think? Like what got you into the teaching space? I should say.
yeah. You know what? I think it kind of started with residency. In residency, we didn't feel the joy of teaching because we just had to
Yeah.
do it as part of all our assignments. But we literally probably every week had one or two presentations per resident. So
Yeah.
we ended up kind of teaching ourselves the course through obviously the guidance of our faculty, but that kind of got me comfortable in front of at least a small group setting,
Yeah.
and just comfortable making presentations. I think a lot of it goes into that part, obviously the preparation.
Mm-hmm.
So, and then in terms of actually teaching other dentists, the first time, actually that course that you took was the first
Yeah.
one I taught. It was, I
Really,
think,
man, you're a
like maybe
natural then, man.
maybe like 4 months after I had moved back to Toronto, and I was juggling a bunch of things. I remember that course very clearly because it was a 3-day course. So the
Yeah.
first day we taught like soft tissue suturing, both FGG and CTG. I have no idea how we crammed all of that into one day.
Yeah.
The
Yeah. Yeah.
second day was all crown lengthening, so kind
Yeah.
of also some perio surgery fundamentals.
Yeah.
And then the third day, we literally took, I think, 6 of the students and we went to a clinic and we did live surgery on 6 patients.
Yeah.
So
Which
they
is
took what they,
unbelievable.
yeah, it's crazy. Like I wish we could do that now. It's a lot tougher now to do that,
Yeah.
but I felt that was the best way to kind of grade myself to see how I did in my teaching because that day was obviously kind of nerve wracking. Like, there's 6 dentists here under my supervision, 6 patients. And
Yeah.
I remember the one thing I told all of them was don't tell me when before you cut the palate because I don't want all of you cutting into the palate at the same time. I can't handle, 6 emergencies at once.
Yeah. Six
So no,
squirting
I mean,
vessels all at the same time, man.
exactly. Yeah, it's not a competition there. So we they did so good. It was honestly that was the most rewarding part, and that kind of got me hooked. A little
Yeah.
bit on teaching. I met Dr. Kwan shortly after that,
Yeah.
and the kind of the rest is history. And I'm so kind of grateful to be part of Bites to meet someone like yourself and all the other faculty. And now we have this kind of brotherhood all across the country, which is
Totally.
which is super cool.
Yeah,
Yeah.
man. And I know exactly what you're talking about. I was just in Toronto teaching. I met up with you there as well.
Yeah.
Man, you get this energy and you just want to share everything. And it's not about ego. It's push all that crap to the side. Let's just teach our skills to each other so we can all be better dentists, hey?
Yeah, absolutely.
Yeah,
Absolutely.
man.
I think I've spoken to other dentists, like especially older dentists and older
Yeah,
specialists, and they really kind of look at teaching in a negative way because they're afraid that if they teach someone something that they won't refer them the case, which I totally understand that mindset, and I'm sure to some degree that happens. But when you teach someone something, I think they eventually they trust you. They look to you for guidance. Now that I've taught more and more students, I have people messaging me with cases, and it's always nice. And I'm sure you have the same thing with your third molars online course. Speaking
yeah.
of which, thank you for the stickers. Look at this. If anyone wants cool stickers like this one, and Nekky has a story for this one, so you're gonna have to ask him about this sticker.
Yeah.
But sign up for his online courses. He's got over
Thanks.
200 videos on
Yeah,
your
yeah,
course.
yeah,
Yeah,
yeah.
that's awesome.
No,
But no, anyway, I
yeah,
think we both kind of share that passion for teaching,
yeah.
just honestly for the sake of the students and obviously the sake of the patients.
Totally, man. And like to speak to the people that don't want to share all your secrets or the older generation of dentists that don't want people teaching. It really comes down to an abundance versus scarcity mindset. There's
Yeah,
more than enough patients out there that will get referred to where they need to. And if we teach all of the dentists around us to be better dentists, man, it just helps patient care overall. And so,
yeah,
no, I don't subscribe to that fact. I'm a big abundance mindset guy. And as I'm
yeah,
sure you are as well, Jeff. And man, honestly, from the bottom of my heart, thank you because you've taught me a ton of perio skills. You and Dimitri, like you guys have really, really helped me out a lot. But I want to ask you another question about your story because like I grew up in Calgary. I'm a first generation immigrant and my dad, he would have given both of his legs for me to go to an Ivy League school. And look at this dude. You go to an Ivy League school, UPenn. What's that like?
honestly, it's like every other school. Like I'm not just saying that. Like dental school I enjoyed dental school, but when looking back, I think I could say that. But during dental school, I don't think any of us enjoyed dental school, right? You're
Yeah.
you're bombarded with classes and studying and exams.
Yeah.
I think what really made Penn special for me was my class. So we had an incredible class. We used to have this competition every year in September called September Fest, and it was kind of like an Olympic game style type of competition between the 4 classes. And
Yeah.
usually it's the first years that win because they show up in greater quantities. They have more participation. A lot of the events are based on quantity.
Yeah.
But my class literally won this competition every single year we were there.
Oh
So that just goes
yeah.
to show like how close knit, even in our third and fourth years, where half the people are probably thinking about their next step after graduating, and
Yeah.
they're
Hmm.
worried about interviews for residencies. So no, we had a really special group. I met really special group of close friends that I
Yeah.
would say are still my closest friends to today. So and then the last thing was I was part of student council, and I think that kind of
Okay.
was a distraction for me. A lot of people looked at it like, wow, like when do you have time for that? But honestly, it was just a good distraction to away from the schoolwork, away from the stresses of clinic that we all had.
Yeah.
But no, overall, it was a great place to go to
It's the
school, and
people, right?
for sure, yeah,
Yeah. It's the people.
yeah,
And dude, I know you taught at Harvard too. That's me bragging for you. That's like the little kid inside me that went to Boston just so I could buy a Harvard sweater, but not good enough to actually get into school there. So, dude, kudos to you, man. You're an incredibly
thanks.
smart, successful dude. And I know like you have your Perio office in Toronto now, and like, man, like I know you're involved with other like GP offices as well. What are like the practice differences between a GP office and a perio office? Like, how do you guys run your offices differently? Because you guys are 100%, usually referral based. How do you run the office? How do you get referrals? How do you approach GPs? Like, how do you make this all work for you, man?
Yeah, so I think, I mean, as you mentioned, there's a huge difference there.
Yeah,
And at this point, I get to see both sides because I also go to some GP offices to do the perio work for them.
yeah,
And there's definitely a difference. I would say, so kind of starting back in Boston, when I first joined my associateship, it was a pretty well-known perio office, and I thought when I first joined that, oh, I'm going to get busy very quickly because these people are well known. They've kind of worked with all the dentists in the area. They're going to just start referring me stuff. Maybe smaller cases at the beginning that they don't want to do.
yeah.
But I was wrong. I was wrong about that, and it was a great, not rude awakening, but just a realization of the reality that I had to build my own practice within their practice, right? And actually, ironically, the biggest competition were the other or the other periodontists in that
Oh,
practice
really?
because
Okay.
they had farmed out everything already, right? So
Ah,
I couldn't take any of their referring dentists, right? So they had
mm,
already kind of cherry picked everything.
all around
So
the
I
area.
remember I would just spend, lots of days traveling with one of the reps to go to offices, and the reps liked it because sometimes they would get turned down at the door. But if
Yeah,
they bring a specialist along, they
yeah.
might
Then they have to come
actually
in,
get
right?
to see the dentist. So
Yeah, yeah, yeah.
there was a lot of door knocking. I felt like one of those like knives salesmen going from door to door.
Yeah.
Um,
So like cold calls, basically. Hey.
Yeah, pretty much. We would just pick
Really?
out a couple of offices on the way that the rep would either know a little of or none at all, and we would just go and and see what we would get.
Dude,
And
that's
the
got
other
to be
thing,
humbling, man. You go to school
no,
for what, 12 years and then you're cold calling. Like that's,
yeah,
I don't know, but like if I was at your level, I'd assume I'd just walk into this practice and referrals would just be, raining down on me, right? But
yeah,
you're right, that's not the case all the time, is it?
yeah. I think it's just it depends on the practice, right?
Yeah.
Some practices are at the level where they are, maybe the senior dentists there are slowing down and can pass things along, but some practices are not. So no, that was a really humbling experience, but also that's
Yeah.
what got me into teaching more. So we started study clubs. We started trying to get into, no, that's what, where Harvard came from to
Yeah.
kind of go through my network and teach there and try to get some more networking opportunities. So I
Mm.
guess the biggest difference is, I'm marketing to GPs, whereas GPs are marketing directly to the public.
Yeah.
So the strategy there is different. Um, and for me, it's just about that relationship. It's not, I don't really love oh, let me take you out to a fancy dinner. And because
Totally.
I took you to dinner, you should send me a case. Like, I don't really believe in that. Usually it's kind of, it takes two people to shake hands, right? But maybe one person extends their hand first. And usually I'm the one to do that, which is fine, and I think that's how we've slowly built things up with my perio practice.
Totally. What I appreciate as a GP, I refer to my periodontist around me, and I live in a rural area, so my periodontist is 2.5 hours away. The
Hmm.
thing I appreciate with all my specialists, and I don't know if you do the same thing or if you notice that, is when I get texts or communication about patients and they want
Hmm.
me to be a part of the treatment plan, like I think that's so cool. Like they'll send me surgical guide cases and they'll be like, "Hey, what do you think about the position of this?" And it just cements in the fact that like, I may be just a GP that is referring to a specialist for a more complex case, but like, you want me to be part of the treatment plan and it just engages me into the situation. And I think,
Yes.
rebuild relationships for life that way, right?
Yes, absolutely. I totally agree with it. I think it's more the collaboration that you build
That's
as
right.
opposed to you're sending me the patient, I'm taking the patient. It's none of that. It's more, let's work on this patient together and provide them the best care. And I think communication just between the dentist and the specialist is super important because if your communication's off, the first person to notice is the patient.
Oh God. Yeah. Yeah.
Yeah.
Because then they're like, man, but Jeff said this, but Nekky said this, and Nekky doesn't know what he's talking about. He's over there. Yeah. No, I totally hear what you're saying, and I wanted to bring everyone's awareness to your Instagram account because we were just talking about teaching, and you're not you're not one of those look at my case, look how great I am. You're like a dude that actually wants to educate. And so I encourage you all to go to his Instagram account at Dr. Jeff Lee. And he has a ton of great Perio cases. I personally love the quizzes you put up, like, hey, what would I do in this situation? Or what did you do here? That's how
Yeah.
we learn because those are the situations that we learn from. And one of your cases, well, I guess a lot of your cases that you've been posting are about diving into socket shield. And I don't
Mhm.
know what has happened, but you've kind of established yourself as like the socket shield guy in Canada, and you've done a ton of socket shield stuff. I know, like you've taught some courses with Megagen.
Yeah.
The first time I even heard of a socket shield was at the Howie Gluckman course out in
Yeah.
Toronto. And, it was crazy because I don't even know why I was in the room. There was like Canada's finest dentists and specialists. And then there's me in the back on my phone the whole time trying to get Raptors tickets because they were playing Philadelphia that night. And like Hisham Shergan was there. He was on a previous episode. And, I was just trying to get Raptors tickets. I didn't even know what a socket shield was, how they were doing it. So when it came to the hands-on session, I was like, man, what the hell did I just miss?
Yeah.
So, man, enlighten me, man. What is socket shield and why do we have to do it? Because I'm not going to lie, I'm a little skeptical. So tell
Mhm.
me, man, enlighten us
Yeah,
all.
I think skeptical is definitely the right word. I was very
Yeah,
skeptical at the very beginning too, because in dental school we're taught, don't leave a root tip, take
that's
out
right.
the whole tooth, curette
Yeah.
the socket as much as you can, like all these principles, which when you're taught something in school, principles generally become your foundation.
Mm-hmm.
And then for you to kind of step outside of that, maybe outside of the comfort zone, it takes a lot of questioning and a lot of skepticism.
Mm-hmm.
But basically, the general idea of socket shield is that we're leaving purposely a portion of the root. As
Mm-hmm.
long as that portion is healthy and not mobile, then we can leave it. And the idea is to leave the blood supply that's kind of related to that root, right? So the root has PDL cells or PDL fibers that give blood supply to that very, very thin buccal plate. So especially in, let's say, the maxillary anterior, we know that buccal plate is always super thin.
Mm-hmm.
So knowing that and leaving that little piece there, it keeps that blood supply and innervation to that bundle bone that's very thin
Mm-hmm.
and doesn't allow it to resorb. Because we know through decades of research and follow up that no matter what you do to a socket, especially when the buccal plate is thin, if you graft it, if you put soft tissue, all of these things, it's going to resorb. It's just a matter of
Yeah.
time that it's going to resorb. It does obviously vary from patient to patient, but it's going to resorb. So the idea of this is to kind of trick the body into thinking the tooth is not gone. So don't resorb because the tooth is still there. You have nowhere to resorb. And then as long as you kind of perform the procedure correctly and you avoid, loosening the shield or having an infection, it heals just as well as, any other kind of implant procedure.
Yeah. Like, Jeff, with all due respect, I understand exactly what you're saying. But when I've tried to do it, every single time, beyond it taking forever for me to do it, I
Yeah.
feel like it's just not like, did I loosen it? Did I not loosen it? Man, it's getting really close to the implant. Like, did your first couple turn out the same way? Like, were you just 100% confident that you nailed it right away?
No, for sure. I mean, I got lucky the first few. I was very selective.
Yeah.
I think maxillary central incisors are a great tooth to start with because it's right in your vision. You know, you can see everything better. You don't
Yeah.
have to kind of turn things and look sideways. The other thing is the socket is larger. So laterals, for example, I find difficult because there's just not enough space for your implant and bone and not touching the shield. So
Totally.
I
Right there.
recommend first case central incisor, even
Hmm.
though it seems the most daunting. You know, if you pick your case correctly, I think that's the best. But I'm with you. I've definitely had cases where I've planned to do socket shield and
Hmm.
everything, the CT, the X-rays, the clinical radiographs look good, but then during the procedure, either the shield loosened up or there just wasn't enough space or something, and I had to kind of abort, which is fine. Like it's not going to be 100%. I think sometimes the tooth is not mobile, but once you cut the crown off and you start sectioning the root, that portion gets mobile. So it's tricky, but as long as you follow the principles, I think it's a pretty safe procedure.
Hmm.
I would say I've had only one major complication up to date.
Oh, really?
Yeah,
Man, no, that's amazing. So, Jeff, would you mind? Could you walk us through a case?
yeah, yeah,
Yeah.
yeah.
Let's throw up one of your cases here. I'm gonna get you to share your screen here, Jeff.
All right,
Yeah, your screen's not. You have to throw it up in the corner there. There we go. All right.
all right.
So I'm gonna put you. So now we can see your screen. I see. Is that a lateral?
No, this is a central. This
Is
is
that
a
essential?
2-1. Yeah.
Okay, perfect.
So you can see this tooth is already kind of broken off at the gum line.
Mm-hmm.
It's for sure non-restorable. The X-ray is obviously before the fracture occurred.
Okay.
I guess you could argue and say there's maybe other ways to treat this case, like forced eruption, maybe. But I still think you'd be having a tough time to get a good ferrule for your crown. So anyway, we're not here to talk about
Yeah.
treatment planning options. There's always many options.
We're doing a
Uh,
socket shield.
yeah. So as you can see, the goal here is to preserve everything that we have.
Okay.
And this patient, this was a good case selection for me because very good tissue, very healthy,
Mm-hmm.
and the other teeth are in pretty good condition as well. Okay. The other benefit, kind of a side benefit of this, is now that we're doing socket shield on a 2-1, if you look at the 1-1, that tooth, you never know, might end up being the same situation down the road. Right. So us preserving bone on the 2-1 actually could benefit the 1-1 down the road. So that's
Absolutely,
another
because man, I'm
consideration.
always nervous about that. You do an
Yeah.
immediate on upper central, and then sometimes you may place it deeper than you want to, and
Right.
then if the adjacent central goes, now who knows where your bone levels are going to end up, right? So
Yeah.
I 100% respect that fact, and you'll
Yeah.
find you're going to keep your papilla more often as well. Hey,
Right. Because you're keeping that interproximal bone.
yeah, absolutely.
Okay, so
Okay,
let
sorry,
me
go
show
ahead.
you kind of this is where we progress to sectioning the shield. You
Okay,
can even see that we section kind of right through that canal because you can visually see the post
yeah,
and the gutta percha. So what I like to do here is kind of make it not just straight across from mesial to distal, but a bit semilunar. So you're kind of
mm,
seeing that the buccal portion almost has a little bit of tooth fragment left on the mesial and distal. And again, just like what we said, that's going to help keep that bone peak there
yeah.
and keep the papilla there, right? Which we
Okay,
know
okay.
is super, super important. So that's maybe one of the tips I would recommend is to cut kind of in a semi-lunar shape.
Yeah, because it keeps the adjacent bone. That makes sense.
Yeah. You want to make sure, like, probably taking a CT for first cases would be good because you want to make sure you're getting the right depth. So, all the way
Mm,
down. It's like doing
yeah,
endo. You want to make sure you get down to the apex because the last thing you want to do is think that you've sectioned everything and try to mobilize the palatal portion, but
yeah.
it's actually, now causing mobility on the buckle if they're still
Still
attached.
connected. Yeah.
Yeah.
So man, what burr are you using to get
Mhm.
that long down the tooth without it binding on the buckle and the palatal side? Like to
Yeah,
me that
exactly.
was the difficult part.
Yeah, so you need a special burr for this. I use a kit. I use the Howard Gluckman kit from Megagen, the PET
Okay.
kit.
Yeah.
But if you don't use a kit, you just need to find a burr that as is cutting very sharp, but it needs to be that long, and it needs to be on a high speed surgical. It can't be like one of the acrylic burrs, for example.
Yeah, yeah, yeah. Man, I
Yeah,
I personally I find that difficult like to
yeah,
to get all the way through. And then how do you know you're through?
Yeah. So
Is
again,
it
a
just like
lot
a
of that
tactile
depends on.
or yeah.
Yeah, so you can start maybe putting, like a periotome on the palatal portion and seeing if you get a little bit of movement there without, you're always going to put your finger on the buccal gingiva there to
Yeah.
make sure you're not feeling any movement.
Yeah.
Yeah.
Okay. All right. So we've cut through the tooth and now
Yeah.
the
So the
buckles.
palatal portion is removed, and you can kind of see I've overcut a little bit on the mesial and the distal, like we're into
Okay.
bone there.
Yeah.
So you kind of want to avoid doing that as much as possible. This was one of my first cases. And then this is now after I've kind of shaped the shield. So you can see the shield has been brought down below the gum level to basically the bone level. That's what the
Yeah.
inset shows you. Um,
How thick is that buckle piece, Jeff?
so again, that varies. I would say you should leave it at least a millimeter thick, but you can
Okay.
go a little bit thicker, maybe 1.5 to 2 even. What you don't want to is have any gutta percha or any nerve left in that,
Right.
especially the apical portion. And if you have a big socket like this, you can leave it a little thicker because you have still room for the implant. But as I said,
Mm-hmm.
like a lateral incisor, you can't. You want to thin that out as much as you
Okay.
can. Yeah.
Jeff, that looks amazing. First of all, great photo. But second of all, I've tried a couple and I could not get this level of success. So, man, already kudos. This is awesome. Okay, what's the next step?
So the next step is just placing the implant. As you can see, it's placed towards the palate,
Yeah,
engaging palatal bone. So you're not going into where the tooth was, which we know is generally towards the buccal,
right.
right? So the CT helps show us that there is enough bone, like that triangle of bone that we talk about, where
Mm-hmm.
we're aiming our immediate implant. So here you want to make sure it's the right depth, the right angulation. It's away from the shield. It should not be touching the shield.
Mm-hmm.
Um, so that part's really important. And then you want to make sure that you have good stability, just like any other immediate implant, if we're going to temporize, which is the next step.
So, bringing it back a step, would you say, is there certain bone shapes that are better for socket shield success in relation to other bone shapes?
So I think actually the more buccally positioned the tooth is, the
Yeah,
more indication for socket shield,
no
because
doubt,
then your shield will be
110%.
further away from your bone
Yeah.
and you'll have a nice protection provided.
And those are the cases that if you tried to take out the whole tooth,
Hmm.
that's when you're going to get the most collapse back if you don't do the
Exactly.
socket shield. So I 100% resonate with that because I'm the idiot that goes in there and takes that tooth out and then I don't know. I don't even want to get into it. We're not highlighting my errors today. So this is great. This is great. Okay,
Yeah.
so you have your socket shield. How
Yes.
far do you want your implant away from the socket shield? Like what is that jump gap distance?
Uh, I would say what you should go for here is positioning your implant in the most ideal position, right?
Okay.
So position in terms of coming out a little bit towards the palate, position for depth and angulation.
Yeah.
I would say at least a millimeter, and just make sure that there is some daylight there. That's
Okay.
that's what you really need to know.
Could they touch? Like what happens if the socket shield is touching the implant?
Yeah, I was just chatting with someone on Instagram like a couple weeks ago, and there's like this book or paper that's been published recently
That
that suggests that you should have the implant engage the shield. And that's the first I've
really?
heard of it, so I
Yeah.
don't want to spread any like false information, but
Yeah.
I think what you should aim for is to not have it touch, because sometimes because you're torquing this implant in, right? It's turning, it's not getting pushed in.
Right.
So that torquing pressure, that circular pressure, can definitely, dislodge that PDL
I was
fiber.
just going to say that. I thought that would dislodge the shield because it's
It
not
can.
that tight up against there, right? Like if you push on it the wrong way, it will get loose.
Oh, for sure. All you have there is left is just some very thin PDL fibers holding onto a very thin sliver of root.
Yeah. But dude, you nailed it when you said when that tooth is so far buccally positioned, it almost looks like it's outside that biological window. You know what I mean?
Yeah,
It's so
yeah,
far buckled. Those are the best cases to do socket shield. So, no,
yeah.
that's
Because
awesome.
even if you bone graft those, you're as you said, it's outside that window. It's
Yeah.
outside that envelope. So it's hard for us to expect biology to form, where it shouldn't be forming,
Yeah.
right? So we as you know, I think that that's why the highlight of it is to kind of preserve that little shield there, and that will keep that bone out there.
Yeah. No, man, that's wicked. Casey, you go ahead and temporize from there.
Yeah, so I just I place a healing abutment just so I can put some sticky bone,
Mm-hmm.
and then that's the temporary on the bottom left picture, and that's a little PRF poncho, and then that's the X-ray.
Do you
So
always graft your jump graft or your jump gap with sticky bone?
I personally do.
Yeah.
I it just I don't know makes me feel better, I guess, to see that there's something in there.
Yeah.
But theoretically, I think a jump gap of less than 2 millimeters, you really don't have to. The blood clot will form and form nice bone either way.
Yeah. And I like that dual zone grafting you did with your
Yeah,
temporary there. I think
yeah,
that's key, and I don't think that's done enough. So good for you. Okay,
yeah.
so now what?
So that's that's how the patient leaves. This is the 1 day surgery, and that's how they leave, and they just wear their temporaries for a while. And the rest of this is no different than any other implant case, right? So after healing, this is how they ended up
Oh
restored.
wow,
So I didn't do
look at
this
that bone
restoration.
level.
This was a referring dentist of mine that we worked together on. So
Wow.
yeah,
I'm always nervous that like if I did do a socket shield, the patient is going to move away 10 years later. They're going to go see a dentist, and that dentist is going to be like, do you know your dummy implant dentist left a chunk of tooth there? And then it destroys all credibility that you've built. And so how do you talk to the patient about this? Do you tell them you're going to be leaving a piece of your root there?
yeah. I'm always very upfront with my patients because
Yeah.
I think they're all adults, they're all
Yeah.
consenting adults. They need to own the responsibility of the treatment. I mean, it's our jobs to give them the options, to perform the best that we can to our knowledge, but it's
Yeah.
their job to own the options, choose their option, and know what they're getting. So I don't think there's any sense in hiding the fact that we're purposely leaving a root behind. I just tell them this is a relatively newer procedure, although it does have some good evidence, up to 10, even 15 years now.
Mm-hmm.
Um, and I explained to them why. I explained, just like we're talking about in this podcast, I explained to them some of the biology, and why it makes sense. And honestly, it kind of makes sense. Like I would say that most people I explain this to, it just clicks for them. They're like, oh, that sounds good,
Yeah.
and let's do it. And then for the cases that I've, attempted but couldn't do it, they actually get disappointed. They're like, oh,
Really?
we couldn't keep the root. So
Yeah, well, you know what? Kudos for that. I like just judging off your picture there. It looks like the central that you did is better than the contralateral central. So, no, man, that looks absolutely incredible. I love that bone level on the X-ray. Can I ask you
yeah,
another question though?
yeah,
How
yeah.
low does that socket shield have to be below the buccal gingival margin? Is there a guideline? Do you try to go under the actual buccal bone, or do you want it in line with the buccal bone?
So I try to get it in line with the buckle bone, but you can go a little bit more apical than the buckle bone, but you don't want it to be above.
You don't want it to be above the buccal bone. Okay.
Yeah,
And then how would you know, like, knowing me, I'm always nervous about everything. But so how would you know if you put your temporary in there? How do you know that that little socket shield isn't loose or will become loose? Because I know that things like that keep me up at night. Like, it's
right.
not the actual implant. It's what if my socket shield gets loose? Have you ever seen that before?
I personally, um, no, I personally haven't seen like a loose shield after everything's been, restored and finalized.
Yeah.
Again, I think this procedure is quite technique sensitive, and
Hmm.
I suggest either taking a course or reading the papers very clearly and watching videos maybe. Howard Gluckman is probably the best source for this because not only does he have the research to back everything up, but he's also, a big advocate for teaching this course as well.
Yeah.
And there's so much more you can do with socket shield and other ways of preserving the tooth. But I would say if you follow protocol, just like everything in dentistry, if we follow protocol, things work out most of the time. There's always going to be the exception to the rule, but
Yeah.
I don't know, like I guess just do your best, and hopefully it doesn't keep you up at night.
It's usually the dentist trying to think that they're smarter than the protocol and trying to like, skip that step. That's when
Yeah.
things go south. Like say when you're doing an R2 gate guided surgery and the drills aren't even engaging because you're just like going through those motions, you know what I mean? Then you just jump to the
Right.
next, like too far down, and then everything's thrown off, right? So no,
Yeah.
I totally hear what you're saying. But Jeff, okay, honestly, come on. Do we really need a kit for this? Because man, it's a couple burrs, but it's so expensive, man. Like, come on. Like
Yeah.
in my hands, and especially at my office, like I have a large office, things get piled through the sterilization system. My burrs rust so quickly. Like, who's gonna
Yeah.
spend $1,000+ on some burrs that seem like they should be accessible other places? Tell me about why you use this kit versus just getting regular burrs.
Yeah. So I've always kind of been, I don't want to say like a play by the rules or play, kind of follow the rules, but I always think that things are made for a reason. Someone much smarter than me, Dr. Gluckman and the team at Megagen,
Yeah,
much more capable than me, have designed this kit. Like, who am I to say I can figure out a better way to do this, right? And I also think it's about being just um, responsible to your patient, because if there is something, that saying, like, you don't know what you don't know.
yeah,
But if I know that this kit exists and it works well, and I've experienced it and it works well, then I should be using this kit. So I'm not here to sell kits. I'm just saying that it's designed specifically for this. It's like you wouldn't use, you know, a burr for something that is not meant for, right? To cut a
yeah,
crown, for example, you wouldn't use, like, I don't know, a pear-shaped burr, because it just wouldn't make sense. So I would say if you're looking to kind of get into it without getting the kit, then
yeah,
make sure you find the length of the burr and it needs to be sharp.
yeah.
But honestly, the kit has lasted me probably 2 years, and
Oh,
I
really?
feel they're still very, very sharp, most of the burrs. And you don't have to
Wow.
replace the whole kit. You just replace, either
Just
one that,
certain burrs.
yeah, exactly.
This procedure really reminds me of that saying, if you want to do something with ease, you must first do it with intention.
Hmm.
Because this is not something that, is super quick in my hands. It almost feels like it takes longer to do the actual shield than it
Yeah,
does to do everything that comes after the shield.
yeah.
But I feel like you really need to practice this. When you first started, how long did it take you to make the shield versus how long does it take you to make the shield now?
Yeah, so that's a great question, and it has changed a lot. I would say my first case took probably over 2.5 hours from start to finish.
Yeah.
I did have a couple difficulties with that case because she had like this gold post, like cast post, that was impossible to cut through.
Yeah. Yeah.
Um, so I actually had to cut around this post, but
Yeah.
keep the tooth in. So that was quite difficult. That also the temporary, which we had pre-made, didn't look the best and fit the best. So we had to
Yeah.
do some adjustments to that. So I would say at the beginning, the shield probably would take a good 30, 40 minutes just to
Yeah.
do that shield part. But now I can probably do them in 10 to 15 minutes, especially if I'm not taking photos.
15 minutes, man. That's insane. That's wicked. And do you often do guided surgery with a socket shield?
You can. I've done both. Like this case was freehand. I have another case on my Instagram that was with the R2 gate guide.
Yeah.
Both can work well. I would say that as long as I wouldn't say just do guided unless you have experience doing at least anterior immediate implants,
Mm-hmm.
because I remember way back when I first started doing anterior immediates, everything just looked way off. Like you always looked like you were going in the wrong direction,
Totally.
and then you would potentially perforate that buckle plate because you're like, no, it can't be that far buckle, and then you end up drilling in the wrong direction. So
Totally. You can't
yeah,
always trust your guides because
no, exactly.
I remember I perfed the lingual plate on my very first guide, and it was because I supplied an alginate impression versus a
Um,
scanned impression, and it
yeah,
was just inaccurate right off the start, right? So,
right.
no, I think that's a great lesson. Make sure you can do anterior implants, immediate implants at a proficient level before you just jump into guided.
Yeah.
Which brings us, we're on the theme of failures here. I can share. I got a full laundry list of failures, and I'm not hesitant to share them. Now, a dude like you got some special skills. I know I've seen your work. It is absolutely incredible. Does Jeff Lee still get failures?
Definitely.
Really?
Yeah. If anyone tells you they don't get failures, they're lying.
They don't do it enough. Am I right?
Either that or they're
Yeah,
lying. Yeah.
they're lying. Okay, okay,
Or
okay.
probably both.
But dude, man,
uh,
you know what? You got to share a fail. Do you have a case?
yeah, I have a case. It's not socket shield. It's actually the Densa. So let me pull that up.
Ah, dude, I love that, man. Here we
So
go.
Densa is another hot topic, right? Like this
It
is
is.
it's been more streamlined, I would say, than maybe the socket shield.
Yeah, yeah,
This
yeah. Man,
was
I
one of
use
my
Densaburs all the time. I love them for
yeah.
small literal sinus bumps. I was just in Toronto and I was with Jason Adanada in his office,
Mhm.
and he was like, "Man, I've never used a Densa burr before." And we did a 4 millimeter lift, and then we packed autogenous bone in there, and it looked
Nice.
wicked, man. Like, do you like
Yeah.
using Densa burrs a lot too?
No, I love using Densa. I would
Yeah.
say um, I started using them last year because I took the course. I remember I took the course in February in Chicago right before COVID hit. So that was like my last
Oh.
little getaway or going anywhere before the
Yeah,
world
yeah,
shut
yeah.
down. So I didn't really get to start using it till later on in the year. But I guess it's been just over a year now, and I've really, really enjoyed them. I think that it's probably the thing that has changed my scope of practice quite considerably relative
Okay.
to many other kind of instruments, let's say. So this case was, it looks very straightforward. I didn't have a CT to begin, but we can clearly see where the sinus floor is
Totally.
on its upper six. And so I remember I did every single step that they had recommended. This is the one of the pilot drills to make sure we're just below that sinus floor
Yeah.
before using the next spur to break through.
Right.
Uh, all of this is done with high irrigation, the speed recommended, and in reverse.
All right.
So then this is my peri-op X-ray showing that I've gone through the floor, I've lifted the sinus, and I've placed Novabone. So I use Novabone for this mainly because, well, I think Novabone was designed for this procedure. So again, as I said earlier, I like to kind of give things, their due when it's designed for that.
Yeah.
And
What
also
is
the
Nova
carrier,
bone made out of? Like, what kind of bone is
it's
that?
it's synthetic.
Oh, is it? Okay, okay.
Yeah, so I'm a big autogenous and allograft guy. I don't really use xenografts almost ever, maybe once a year.
Yeah, yeah,
And
yeah.
I would say this is the only synthetic or non-allograft bone that I use, but mainly because of the syringe it comes in, right? So it comes with a little kind of like a composite gun, and you
Yeah.
just insert it into this area, which always is quite small, right? It's hard to
Right.
get bone to go up there
Yeah,
into
yeah.
your osteotomy.
And you get the sexiest lifts too, man. Like, come on, that looks
I
wicked.
mean, it does help to visualize. It also just helps you. I mean, it looks good on pictures, but it just helps you be certain that you didn't have a perforation because it would be very obvious if it leaks out.
Yeah. I would say so. Perfect.
Yeah.
Yeah, man.
So this
Okay,
is this
so
is this is looks to me like this is perfect. This
yeah.
is the implant placed.
Man, how
I
does everyone get their implants so straight? Mine would be at like a 30-degree angle. Dude, that's a wicked photo. Okay. Good job. Good job. Okay,
yeah.
sorry.
So I feel good. I mean,
Yeah.
the only thing I remember about this procedure was that the implant torques in very high.
Like
Okay,
what? Like 60?
probably more than that because the torque wrench for Straumann only kind of goes up to 35, and after
Yeah.
that you're just basing it off on how
How
heavy your
tight you
hand.
want to go. Yeah.
Yeah, yeah. But the lock sim, the little piece that's on the implant, the carrier is designed to break at a certain torque.
Yeah.
So I would at least be around that torque. Maybe
Okay.
maybe not past it. So high, I would say. I don't know the exact number.
Okay.
So this guy comes back and, everything looks good. The healing, honestly, everything was perfect.
Yeah.
And when he went to see his dentist to get restored, they were trying to remove the healing abutment. And this is like 3, 4 months later, and the whole implant comes out. So
Ah.
this is what the X-ray that they sent me. And you can kind of see that that dark hue around the whole implant.
Totally.
Right. So this to me is necrosis of the bone from either overheating during drilling or just over torquing of the implant.
Man,
I don't think
I
I
don't
don't
know,
think
man. Like I've torqued implants like a ton, and
yeah.
especially in the posterior maxilla, you didn't think like that would be an issue at all, hey?
Yeah, exactly. So I was shocked. I also was very humbled by this. I
Yeah,
think all failures are very humbling, but it gives us a great opportunity to learn.
yeah.
So to make this even worse, so
Here
we
we go.
removed
I love this.
so I know this is like a two tier failure here. So
All right.
the dentist removes the implant because it was already at the office, it was already loose.
Yeah,
But when he removed the implant, he didn't put anything back in. So we just let things heal up for 3 4 months. I took a CT. It looked like there was decent bone, and so we
yeah.
tried again. Okay, so
Okay.
now this is the next same site. Obviously,
Yeah, yeah.
I did another little bump. You can see
Okay.
the nova bone there, but I placed a shorter implant this time, an 8 millimeter, and also a shorter healing abutment because I really didn't want any occlusal forces to be a factor here.
Sure.
Okay, so again, I think it went pretty well, but 3 months later, the exact same thing happened.
What?
You can see the bone there
Oh,
again. So now my theory for this, and if anyone is watching this and can chime in, I'd love to hear your thoughts. But my theory is that because when the dentist took the implant out, he didn't curettage the dead bone from the area.
yeah,
It kind of healed. There's new bone inside, but there's still dead bone there, right?
yeah.
So when I went back in, put the exact same diameter implant in pretty much the same place, I'm pretty much engaging that dead bone again.
That same bone. Yeah.
Yeah. So
Oh
this time when
man.
I took it out,
Yeah,
I think that's it. But when I took it out, I basically used a burr and made a large cavity.
yeah,
I made sure it was bleeding. It looked and felt like a good fresh extraction socket, perhaps.
yeah.
No perforation into the sinus, and I put new bone in. And we're in the phase of waiting to try again. I even had this patient tested for an allergy to this implant, and
Really.
it came back negative because we were like, well, maybe that's it, but I don't think so. So that's my theory is that, and that's kind of my what I've learned from this case when I would pass on to people, especially if they're starting to use Densa like
Yeah,
early on, is realize that not only are you lifting the sinus, but you're condensing the bone quite a bit. And I know the whole idea is to condense the bone. I understand, but with that and a high insertion torque, this can happen. So just kind of a word of warning because you're kind of crushing all that bone and condensing it, eliminating all the marrow space and the cells that can go in,
yeah,
and then you're torquing an implant, an inanimate object in
yeah.
that requires that blood supply, and it's not there anymore.
But man, what about like, what if it's like a whole other issue? Like, what if it's like a vitamin D deficiency,
Hmm.
or there's another systemic health issue? Um, do you ever, when you have like, I guess, two failures in a row, are you sending them for blood work? I know you said an allergy test, but are you sending them for
Yeah.
other blood work as well?
Yeah, so that's a very good point. Actually, one of my co-residents at Michigan did a study on vitamin D and how it affects implants.
Yeah,
That's a very good point. I think that's really important to do. That's something that he's, I think, getting done soon. I mean, we
yeah,
just got the implant out, so that's all kind of in the works. It's very, very important, like you said, to kind of make sure as much as we can before we do try. I mean, two failures is definitely very rare.
yeah. Jeff, I know it's rare for you, but I've had it happen to me.
Yeah.
And honestly, it's humbling when I see a guy of your skill level that, shit still happens to you because
Oh,
sometimes man, I live in a rural area. I don't get to talk to so many people about my cases, and I think this happens, and it's important to know for all us dentists that are scared to share our failures. If we don't
mhm.
like learn from each other, how else are we going to get better? And dude, thank you
Yeah.
so much for showing me that because I've had that happen to me, and I feel so much better that it's not just me that this crap happens to, right? But I
It
still
happens to
love
everyone.
densivers though, and
Yes.
and
No, definitely.
yeah, my very first R2 case ended up in the same failure. And my response back I got back was, you overheated the bone. And I'm like, no, man, like I irrigated the crap out of that. But sometimes you have leftover cells from, either a bone graft or a site that just didn't heal properly. So there's always multiple factors in play. So Jeff, man, I really appreciate you. Really appreciate you sharing that. But man, I was just in Toronto. I got to hang out with you. We could talk about dentistry all day, and we did at
Yeah.
dinner, and it was so awesome to hang out with Jason and Mark. And how cool is Mark's magic tricks? He's gonna come on the show, and you're gonna see it. That guy's next level
Yeah.
denture and person. Like I like him more as a person than I do him as a denturist. So it's always fun to hang out. But every time I meet up with you, we always got to go get something good to eat. We always got to hang
Yeah.
out. I bring my girlfriend. You bring your wife, your awesome wife, Jacqueline. Dude, what do you like to eat? What do you like to drink? What's your favorite cocktail? This I want to know about you. I think I know
You
what it is.
already
But
know
what is
this,
it,
but
man?
for all the
Yeah,
viewers, it's definitely an old fashioned.
yeah.
But as you know, I like mine half sweet because I don't love the sweetness of it.
We're at the bar, and here he is. There's six of us at a table. I'll take my old fashioned half sweet. I'm like, come on, man. No, that's cool, man. But what about food? What do you like to eat in Toronto? I'm coming back, man. Where are we gonna go eat? What do you like to grab?
Do you like seafood?
I like it all, man. You got
There's
to
this
tell us
place
your secret.
called Yeah, there's this place called. It's not a secret. Everyone knows of this, but this place. It's a place called Lobster, Fisherman House.
Okay.
And the restaurant itself is really cool because it's like a big room, and the whole outside is lined with tanks, and all the tanks are filled with lobsters and crabs. And I'm talking like Vancouver king crab
Yeah, yeah,
and
yeah.
ginormous, like 3, 4, 5 pound lobsters. So,
Really?
and the coolest part of this restaurant is that you tell them what you want. So you order off the menu, and they usually come in like sets, and they cook your crab or lobster in so many different ways.
Yeah.
But before they cook it, they bring out the actual lobster or crab you're gonna eat, and like let you take a picture with it or just see it. They like weigh it in front of you. And these things are so big they can't carry them out. They literally
Yeah.
put them in a bucket with a string on it and just tow it out like across the restaurant to your table
What?
just so you kind of see it before you end up eating it.
Yeah, yeah, yeah. Dude, you know we're going here. This sounds
Yeah.
absolutely amazing.
No, that place is a riot, and they give you gloves because of how messy it gets. So there's
Oh,
a box
really?
on the table.
Oh man, that sounds awesome, dude. Well, we're definitely gonna go there. Jeff, I truly, man, I appreciate you. Thank you for always letting me ask you questions. And I know so many people on Instagram are always messaging you for questions. You're an awesome dude. You're a good periodontist, but you're an even better friend. So I
Thank
appreciate
you.
you, man. Thank you so much for coming on. And yeah, reach out to Jeff at Dr. Jeff Lee on Instagram. And yeah, thank you so much for watching, and we'll see you guys next week. Have a great day, everyone.
See ya.
See you later.